Hi, I'm Andrew Wakefield. I'm going to be a junior at Hawkins School, and I am in the radiology internship program. My study was on pain control after spine stereotactic radiosurgery for metastatic prostate cancer. External beam radiotherapy is the conventional way to use radiation to treat cancerous tumors. It does this by damaging both the healthy cells and the cancerous cells in the treatment area. You can see the treatment area in the picture at the right in the rectangle towards the middle. And you can see inside of there that the target is in it, but there's also some margin of healthy tissue. But that is okay that there's healthy tissue because the dosage, the radiation is delivered in low doses in multiple fractions or intervals. So between those intervals, there's time for the healthy tissue and the healthy cells to repair themselves, while the cancerous cells do not have the ability to repair themselves. So stereotactic radiosurgery is a newer form of external beam therapy, but it has some key differences. First of all is the number of fractions that it's given in. It's usually one fraction, but it can be as many as 5. Actually, all of the treatments in this study were one fraction only. But to account for the lower number of fractions, there has to be a larger dose so that the treatment can still be effective. But the larger dose makes it challenging or impossible to have such a large treatment area because the healthier cells would not be able to repair. So if you look at the picture at the right, there you can see that the tumor is in purple and that the lines around it are form-fitting and they fit just to the tumor and they avoid the yellow spinal cord. SRS, the actual treatment is a lot shorter because it is in one fraction, but the planning period can be up to a week, so it's longer than EBRT. All of the patients in the study had prostate cancer, and so here's a little bit on prostate cancer. If you look to the right, you can see that at the very top are the normal prostate cells. They're regular, but as you move down, you see that they become more and more cancerous and irregular. Prostate cancer is behind skin cancer for the most common cancer in men, so it comes in at number 2. And in most cases, prostate cancer is very slow growing, but when it metastasizes or spreads to other parts of the body, it usually goes to the bone, and that includes the spine. When the cancer goes to the spine, it can be very painful for the patient. So we wanted to know if EBRT or SRS was more effective in controlling that pain. We hypothesized that SRS would be as good as or better than EBRT in controlling that pain for the metastatic prostate cancer patients. To test this hypothesis, I looked at 38 SRS and 66 EBRT treatments through the medical record systems EPIC and Mosaic. I looked for many categories of information, maybe the most important of which was the patient's pain scores to assess pain control of the treatments. And this was from the brief pain inventory assessment, which is just a scale of 0 to 10 that the patient rates his own pain on. 0 being no pain, 10 being agonizing pain. So here's the first of 2 data tables. It's comparing EBRT and SRS. You can see that the age of the patients in both groups is almost the same, which means that it's a good comparison. But it's interesting that the EBRT patients had a lower KPS, which means that they're in generally worse health. KPS is the Karnofsky Performance Status. It's a scale of 0 to 100, 0 meaning the patient is dead, and 100 meaning that the patient is perfectly normal and fully functional. And again, we're just comparing EBRT and SRS. It's interesting to see that the EBRT patients, a higher percentage of the EBRT patients had metastatic cancer at the time of their diagnosis, meaning that their cancer was further along, it was more progressed by the time that it was diagnosed. So here, this is 1 month after the treatment. You can see that EBRT and SRS are very similar. There's a higher number of unknowns in EBRT, but aside from that, they're very similar. By the time of the last follow-up for the patients, those treated with EBRT were doing better, and those treated with SRS, there was double the percentage of EBRT of patients that reported to be worse than they were prior to treatment. And so when looking at how long it took for the pain to improve, we see that SRS improved much quicker than EBRT. But it's very important to look at the p-value here, which is 0.2564, which is well above 0.05. This means that the data is not statistically significant. And here this is showing how long the pain relief lasted for the patients in each group. And we can see that they're almost identical. They're very similar. And so, in conclusion, 1 month after treatment, SRS and EBRT were very comparable. But by the time of the last follow-up, SRS appeared to be worse than EBRT in controlling recurrent pain. But we have to remember that the EBRT patients did not survive as long, which makes it very difficult to assess long-term pain control. So because of this, we have to look at the 1 month time point to compare both modes of treatment. And because there's no clear advantage to either SRS or EBRT, patients with a poor prognosis, we recommend get treated with EBRT because of the quicker treatment time due to the shorter planning period prior to treatment. And I would like to thank Dr. Jay Siski and Chandana Reddy, my mentors, Dr. Tufik Jamil, Dr. Liliana Angelov, Dr. Samuel Chow, and the Office of Civic Education Initiatives. Thank you.